Hi,
All
Greg.
right, welcome everyone. Thanks for being here tonight for our Tuesday night edition, Emerging Questions in Glaucoma Management. We have our honor, OEC's honor, to have Rich Madonna, an OD, a fellow of the Academy, who is from New York, works at SUNY, past chair, Department of Clinical Education, former chief of staff of ocular disease and specialty at the college. He practiced clinically at the University Eye Center, and it's limited to glaucoma. He has lectured nationally, internationally on glaucoma and ophthalmic imaging. Rich is a great guy. It's no doubt that he has received numerous clinical awards. He most recently was awarded at the American Academy of Optometry the Vincent Ellerbrock Clinical Education Educator Award and New York State Optometric Association Educator of the Year Award. But I can tell you that after all of that, Rich is really proud of his grandchildren, and he gets to go to San Diego and see those grandkids.
I should have put some
Rich,
pictures in.
yeah, got to put some pictures up there, Rich. Rich, thanks for being here tonight. You know how Joe and I feel about you. I think the audience is going to truly enjoy your lecture and these emerging questions in glaucoma. Listen to your virtual round of applause. The floor is all yours.
Thank you, Greg. I just want to thank Greg and Joe for not just inviting me, but for all that they do for optometric education. I mean, they put an amazing amount of time in, and looking at the programs they do, they are certainly timely. And I just hope I can reach the standards that they've already set. I also want to thank Vanessa, Vanessa McDonald, who's been working with me to get everything done. So again, thank you all. So we've got a lot to talk about. I could probably do this for 5 or 6 hours, but we'll try to keep it down to a couple. And as the title says, in my mind, at least, these are some of the most important questions that need to be discussed when we think about managing our glaucoma patients. For some of you, some of this information will be new. For some, it'll be things you're grappling with on a day-to-day basis. And for, I think, all of us, some of it will be things that we'll be looking to do in the next few years. It's certainly not all inclusive. There are so many things out there in glaucoma right now. Greg and I were both just at the Optometric Glaucoma Society meeting, and there's just always a lot of new things to think about, and at least some of those will be in here. And I was thinking that the last slide, which I didn't put in, would be things we're going to talk about in the future, including what I don't have anything about AI in here, but the next iteration of this course will certainly have AI in it. Okay, so that's the background. So let's make sure everything's working. I've got a laser pointer there. The slides hopefully will advance right now. There we go. Those are my disclosures in the last 2 years. And we will be talking about products that come from these companies. However, I believe all relevant relationships have been mitigated. In other words, it should be clear that I'm not preferentially speaking about some of the either drugs or devices from these companies. And if I feel that we're even closing in on some of those things, I'll make sure that I mention this again. So this is the course description. I'm just going to read it so that you have it and we're thinking about it. Modern glaucoma management is challenging due to the rapid advancement of research and new technology, excuse me, that makes it very difficult to stay current. This course discusses approaches to some of the emerging questions in contemporary glaucoma management. Additions to the glaucoma evidence base are emphasized, along with real-life treatment approaches. So that's the background. It's a very broad description, allowing me to kind of talk about anything I want to talk about. So here we go. All right, so what I'll essentially do in each section is I'll kind of mention an issue or an issue that's out there and follow that up with a statement, and then we'll get into the topic, and hopefully Greg and I will have an opportunity to speak about some of it. So the issue is, it's very clear that there are structural changes in the macula in early glaucoma that are routinely measured by OCT. Now, I was trained, I graduated almost 40 years ago, and I always say that most things I was taught in optometry school are true or mostly true. One thing that was false was that we were told that there were no changes or the macula was not affected in early glaucoma. That's clearly just plain wrong. And if that's a surprise to you, then hopefully the next few minutes will help you understand that. Not surprisingly, then, if we have structural changes in the macula, corresponding changes in the central visual field are also measurable. So how should we test the central part of the visual field? So the question on the table is, should I use a visual field test that increases sampling of the central 10 degrees of the visual field? So that's our first discussion. So just as a very brief review, and I think, I think it's very clear at this point in time that if you're using OCT on your glaucoma patients, you should always get a disc cube and a macular cube. So on the left, we have a disc cube, which gives us information about the disc and the circumpapillary retinal nerve fiber layer. It gives us structural and quantitative and qualitative information about the disc and retinal nerve fiber layer. And we should also be always measuring the macula and getting a macular cube scan, which again gives us quantitative and qualitative information about the macula. And these things are maybe a little different from device to device, but for the most part, you're going to get, regardless of whether you're using a Zeiss device or a Heidelberg or an iView or a Topcon, whatever the case may be, you're going to get similar information. I ask that you remember the anatomy, and if we look at this right eye and look at the pattern of nerve fiber bundles as they enter the optic nerve. So here we see the papillomacular bundle. Here's the horizontal raphe, the inferior retina, the superior retina as these nerve fibers project to the nerve. And if we stitched together a macular cube scan and a disc cube scan, we'd get something like this. So here we see the macular cube, here we see the disc cube, and it reminds us in this patient who has lots of loss, a so-called, well, there's a million names for it, a squeegee or windshield wiper sign, a nautilus sign, whatever the case may be, that indicates that damage to ganglion cells in this region, those axons project into the optic nerve through here. So these bundles are coming right through here. So you see a notch, a wedge, and again, this change within the macula. So this would be a bundle that's right in here. So these are all related. And that's why it's important to take a disc and a macular cube scan. And I just outlined the bundle defect for you there. Don Hood, who's done a lot of work in looking at macula in glaucoma, has reminded us that in the majority of patients, the center of the macula or the fovea on the horizontal is below the center of the optic nerve. As such, fibers or axons that come from the inferior part of the macula project to the inferior optic nerve. And we know from information that's 40, 50 or more years old, that the inferior and superior poles of the nerve, those axons are more susceptible to damage. So he has coined the term the macular vulnerability zone. So these ganglion cells are more apt to be damaged. Not in everyone, but in those who have typical anatomy of the fovea being below the center of the nerve. Those that are the ganglion cells that are above the horizontal raphe and in the papillomacular bundle, those axons project to the temporal optic nerve where they are less vulnerable, they are less apt to be damaged. And those outside the macula up here and down here, those are the ones that we always talked about way back when. Those are the ones that give you the germ scotomas that were theoretically the earliest changes in glaucoma, which we know is probably not true exactly. And there is, again, just a cube scan or a thickness map of the macula showing, again, this squeegee defect, which is most typically seen when you see macular changes early in glaucoma because of this macular vulnerabilities. So that's our background information. And now we have a polling question.
And I'm going to launch that polling question. And Rich, you sound beautifully, but we've lost your camera.
Yep, there it goes again. I'm not sure why that keeps happening, but we're going to go back to it. And
so while you're doing that, what is your current approach to using a 10-2 visual field in glaucoma? Only advanced / end stage glaucoma, Only when there is a clear-cut thinning of the macula on the OCT, or when there is a flag central point or points on the 24-2 on all patients, or simply never. So 24-2, what's your approach out there in your glaucoma patient?
I'm going to not play with the camera right now because it seems to pop off when we switch for some reason. That is annoying.
Let me see if that helps.
You want me to hit that?
Yep. There you go. Yep.
And
Went back off
right
again.
back off. Yeah, so let's hold on that. I'm sorry about that. That's horrible.
I'll do it one more time. Let's see what happens.
Yeah, it comes on and goes right back off. So let's see if we switch when we switch back.
Okay. So let's see here, Rich. For your answer to your polling question, you have 18% for, or 16% for A. I'll display the answer. You won't be able to see it, but I can see it.
Right.
You have A, 16%. You got B at the highest, 58 or 60%. 17% went with C, and you have 10% or 9% that had never do a 10-2. So I think this is an appropriate discussion.
Well, it really
Based,
is.
yeah.
And I'm glad to hear those numbers because it's changed over time. So yeah, go ahead, Greg.
Yeah, no, I was just
trying
saying
to
it's.
get
I think your topic is appropriate for this right now, because I think we need to realize that glaucoma is a macular disease. I think is where you're going with this.
I certainly agree with that. I mean, again, something that we didn't think not that many years ago, but we cannot ignore it. And I think a lot of people are imaging the macula with OCT, but then the question is what to do with the visual field parts. It's like saying, well, if I don't sample the macula after getting the structural structural information on the macula, it's somewhat similar to getting the circumpapillary retinal nerve fiber layer information from the OCT and not doing a 24-2. That's not exactly true, but it's close to true. Now, am I back?
You are not, but let's ask one more time. Oh, there you are.
There we go.
Now you're back. Oh, then you went back off.
I don't understand what's going on.
Well, it's probably a Zoom thing, and we're not going to do it. We probably have to have you log off, log back on, but
We don't want to do
we'll
that.
go with you kind of coming and going. So
yeah, let's see what happens when I go forward one slide, and hopefully that'll come back on. That's really aggravating, but I don't want to waste time on this. Okay, so yeah, it's jumping out every time.
okay.
Okay, so let's go forward and maybe we'll give it a try in a couple of minutes. So the current approach is to sampling of the central 10 degrees, which is really what the polling question got at is. The traditional approach, what I was taught is you only need to sample the central 10 degrees in advanced glaucoma. In other words, end-stage glaucoma, when fixation was being threatened. Another option, the one that most of you picked, was when there's a clear-cut thinning of the macula on OCT, or when there's a flag central point or points on the 24-2. And over 50% said that, and I think that's the trend right now. But there may be a third option, which is to consider doing it on all patients. So let's just get into that a little bit more. Okay, so this is a paper that came out 7 years ago. Most of the folks are from Columbia in New York or out at UCSD in San Diego. And they spoke to the fact that we may miss certain defects if we do only a 24-2. So they outlined something like this. You could have a situation where you have a 24-2 visual field defect that also has changes within the central 10, these 12 points that outline the central 10 degrees. And all the 10-2 does is show you how extensive the defect is. Another option, though, and an important one, is what if you have a normal 24-2, including normal central 10, yet that when you do a 10-degree field, you see numerous, or at least 4 or 5 or more points that are flagged on the central 10-degree field. So the 24-2 has completely missed it. And then you have what we've seen forever is the 24-2 Jerem type scotoma that misses the central 10. So this is the important one for our purposes right now. So if we look at this, what this comes from Don Hood's work, but it's very clear cut. What you have is a 6x6 macular cube centered on the fovea. So you see the thickness map from the OCT, and then the points from the central 24-2 are these squares, which have been placed on the fundus and OCT image, giving you a sense of how much space there is between the points on the 24-2, even though we're concentrating on our macular scan, look how much ground we're covering here. Look how much we're measuring within the macula. That's not being tested by the 24-2. So that's really the issue right here. So a quick review for you. Here's a 24-2 field on the left. And if you remember, it has 54 points, 6 degrees apart. And the points that we're looking at in the central field are these 2, these 4, these 4, and these 2. 12 points are the ones that we've outlined before. So if you want to further sample the central 10 degrees with a central 10-degree visual field, you get 68 points within the 10 degrees, and the points are 2 degrees apart. And therefore, this increased sampling allows you the opportunity to detect more subtle defects that might be missed on the 24-2 visual field. So here's an example of that. On top, we see a 24-2. Now, this one is obvious. There's clear-cut damage in the central region that you see here on the pattern deviation plot, but it's not that extensive. When we run a 10-2, though, you could see that this is a very, very wide arcuate type scotoma within the central 10 degrees. So I don't think anyone would miss that 24-2 defect, although 25 years ago, we might have completely blown it off. We might have said, well, geez, you know, that's not really important because it's in the central visual field, and we don't have to worry about that in glaucoma. Clearly, that's wrong now, and you can see the relationship between those two. Here's a more subtle defect that comes from Don Hood's work. And this arrow is just showing this very little bite out of the ganglion cell layer, or rather the retinal nerve fiber layer. The 24-2 is normal, but the 10-2 shows this very subtle and shallow defect on both the total deviation and pattern deviation plots. So this was a person with early glaucoma, but he's showing central damage, not 24-degree damage. So if we kind of
Hey, Rich,
look
can
at
you go back? Can you go back here real quick?
Surely, of course.
Yeah. So I mean, this is one here that, you know, when you look at that OCT, you might not pick up on that defect. You're opening up kind of that segmentation. He's showing that dropout there, and here this is kind of the function. The visual field is picking up the defect before really it's obvious on the structure. So you know, this here to me looks like function over is winning because you're doing a 10-2.
That's an interesting point because it is easier to see on the visual field. However, if you look here, this is actually an Enston plot where, and I'll talk about that in a second, where nasal is placed on the outside rather than the typical T-SNP plot, allowing us to put the macula in the middle. And if we look at the peak here versus the peaks here, you can see there's a slight little depression right here. So the Enston plot shows this depression in the macular thickness right in this region. Or Don will always talk about looking more carefully at the B scans. The manufacturers, however, don't really give you a big B scan to allow you to see changes such as that we see here where this arrow is pointing. But you're right, it might be an opportunity for someone to say, hey, the function may be outpacing the structure. I'm not 100% sure that's the case, though, in this particular image.
But someone might look at this and say, oh, everything looks pretty good. 24-2 might look at that quick OCT quickly and not pick up that subtle defect and go,
There is
okay, your
absolutely
pressure's.
no question about that. Yeah, and these are the types of subtle cases that can be missed. So yeah, I couldn't agree with you more. But the 24-2 in this case is perfectly normal. So this would be the type of case where oversampling with the 10-2 would increase your ability to detect early glaucoma. So if we summarize some of this, the advantages of doing a 10-2 visual field is it'll find central loss missed on 24-2, clearly. Now again, the reason that this is a question and a debate in glaucoma, and the reason that more of you picked you'll only do the 10-2 visual field when you see change in the macula, is because this 24-2 visual field may find some of these patients by picking up just a defect in that central 10 degrees. But the 10-2 will clearly give you greater sensitivity. Another important thing about the 10-2 is its predictive value. There are a number of very interesting studies that show that 10-2 loss actually predicts progression and fast progression on 24-2 visual fields, not predicting more 10-2 loss, but actually predicting 24-2 loss. And this work has been done by my colleague at SUNY, Michael Sullivan, me. He started it when he was at Albuquerque, VA, and now he's at SUNY. And his work has shown how important 10-2 is in predicting 24-2 loss. And the 10-2 loss, not surprisingly, has associations with major effects on vision-related quality of life because we're talking about the central 10 degrees. So things like contrast sensitivity and reading and so forth are affected by loss in the central 10 that you may not want to miss. The disadvantages of the 10-2 are not surprising. It takes time. Are you going to do a 24-2 one visit and a 10 the next, or do them both the same day? Obviously, that's going to have major effects on patient flow, and it's going to cost. You may get paid for a good number of those by insurers, but it's still going to cost you chair time. So these are the things that you're going to need to think about when you're thinking about this particular issue. So I just want to go through a couple more things here. These are, on the left here, you see a T-SNIT curve. So this is the typical T-SNIT curve of laying out flat the circumpapillary retinal nerve fiber layer thickness. So we go temporal, superior nasal, inferotemporal with nasal in the middle. We didn't care about that 25 years ago because we weren't worried about the macula. I really recognized that this was a big mistake, and the Enston curve makes much more sense because if we take the same data and just lay it out nasal, superior, temporal, inferior, nasal, you could see how much easier it is to see that there is thinning within the macular region. So the devices now, most devices allow you to switch from T-SNIT to Enston. And I encourage you to look at Enston curves because you could just pick up the macula so much easier, whereas the data on the T-SNIT is split between the right side and the left side. So in this patient who shows inferotemporal change particularly, you can point to on the T-SNIT curve, the area of thinning, but on the Enston curve, it's right in the middle. Much easier to see. So again, without getting too much into talking about particular companies' programs, I will mention a couple. Octopus has been sampling the central 15 degrees for years in their G programs and their M programs. So you can see here nicely how it's actually in central 15 degrees, how nicely we pick up this inferotemporal field defect. But I do think it's important, and again, Zeiss was one of my disclosures, but because they have such a large percentage of the number of visual field devices out there, I think it's important that we mention the whole debate surrounding 24-2C programs. So again, I'm not advocating for it, but I do think it's important to mention. So on the 24-2C, if you're not familiar with it, what you're seeing is the gray circles are the 24-2 points. So those are the ones that have been there for many, many years now. The 10-2 points are these small gray ones. Remember, they're 2 degrees apart. But what they did was they added, because they wanted further sampling of the central 10 degrees, they added 10 points. Those are in orange. 5 are above the horizontal and 5 are below. And you can see they're not symmetrical. Those 10 points were chosen because they were the most likely to be damaged in early glaucoma. So a lot of data went into this to determine which 10 points. So now you can do a 24-2 visual field with the added benefit of having these extra 10 points within the central 10 degrees. And here's just an example of a patient with some very shallow defects. You could see -4, -2, etc. But you would probably miss this patient if you only did a 24-2. On the 24-2C, you can see you pick up this point, this point, this point, and this point. So it becomes more obvious that this patient has a fairly shallow inferior arcuate scotoma within the central 10 degrees. So that's really the nice advantage of the 24-2C. And using the example we showed you before, there's the 24-2 up top, as I showed you, the 10-degree field nicely showing the extent of that scotoma. And here's what it looks like on the 24-2C. These are all the same patient. And you can see that you get the sense of that arcuate scotoma without doing the 10-degree field. So that's the whole idea of the 24-2C. The problem, of course, is if you're doing 10 more points, you had to be concerned about more time. So again, I'm talking specifically about Humphrey right now. Humphrey came out with what's called SITA faster. So if you have a Humphrey field, or you have other devices that really kind of use the 24-2 pattern and some of the similar types of algorithms as SITA, we see that SITA faster is 50% faster than SITA standard and maybe a third faster than SITA fast. And this slide shows about 4 minutes for SITA faster. It's faster than that. Most glaucoma patients are around 3 minutes or even less. So when you run the 24-2C, you need to run SITA faster as well so that you don't get that increased test time. And that's where a lot of the controversy has come. SITA faster has a number of ways to decrease test time, and they're listed for you here, and you can read about this on your own. But essentially what it does is it makes a lot of assumptions. It doesn't test the blind spot, etc. So it's different. It's really a different visual field. So really, to summarize this, because we could talk about this all night, SITA faster is unquestionably faster. That is indisputable. But there are questions about the interchangeability with previous iterations of SITA, either SITA standard or SITA fast. Humphrey says they're interchangeable, and you can interchange them if you have the right software. But many people in the literature seems to think that many people feel that we should be very careful about switching from SITA fast or standard to SITA faster. I think increased false positives are seen with SITA faster, whether that's because of the speed of the test. I'm not 100% sure. So I think what many of us are doing is we're finding that SITA faster and the 24-2 are very useful for first-time patients because it allows us to test the 24-2 visual field, but also increase sampling in the central 10 degrees, which is the way I've done it, and a number of us do it at SUNY. Gus DeMarias, who's one of the great researchers in glaucoma, who's one of he's our surgeon at SUNY. Gus mentioned this at OGS and said this is the way he tends to approach it as well. But I'd be very careful in utilizing 24-2C and SITA faster in following glaucoma at this time until more work is done. So that's what I have to say about that. And I really apologize. I'd like to see you guys or have you see me. But this is not seemingly to go. Oh, It switched to my other camera, which means you're gonna look at the side of my head, but maybe we'll leave that, Greg.
Yeah, that's fine. Whatever you feel
Okay.
comfortable with.
Yeah, you see the Grand Central picture, and I'll occasionally look over here so you can see me because I've
All right.
got two cameras and this one won't go off. So I again apologize, but that's what we got. So Greg, any comments on this?
Yeah, I figured this would probably spark a little bit of comments. And the first thing is we have some people with the polling questions not popping
Great.
up. If you want to put your, I'm gonna let them know if you want to put your answers in the chat box, that's totally fine.
Yeah, please.
And so on, so on and so forth. Regarding some of the questions that are rolling in, let's see here, where was it? They're kind of got lost with what should I do about the polling questions. Same for me. Let's see. It says, I have personally taken a 10-2 and found to be more difficult than a 24-2 to be tested with. Is there any statistically study on patients' accuracy and age with a 24 or a 10-2?
That's a wonderful question, actually. And I would almost bet there is, but I can't cite it off the top of my head. But it's a great question. But I think if you look at studies with that, I would almost guess that because we often use 10-2 visual fields in advanced glaucoma, that most of those studies may have been done on patients with advanced glaucoma and not with more early glaucoma, which is what we're talking about here. But I think that's a wonderful question because it really does get to the issue. And I agree with you. There's a lot of points in a 10-2. And so it can be a more difficult test in some cases.
How do you sort out the noise in a 10-2?
I think you sort it out the same way as you do with any visual field. You have to recognize there's lots of variability in any visual field. Even in patients who are good field takers, we know that there's variability. So the best way to sort out noise on visual fields or on OCTs is by doing more tests. The more tests you do, the tighter your confidence limits are going to be.
There was a question up here earlier, and they might have taken it down. It says, do you do a 10-2 and a 24-2 at the same, at the same visit?
Yeah, and that's really the issue here. In a perfect world, it would be wonderful if we could do both every visit or even alternate them. But the problem is, as some glaucoma experts say, every time you do a 10-2, you're missing an opportunity to do a 24-2. And that's where this controversy really lies right now. My feeling about it, and again, you're going to hear lots of different things from different people. My feeling is 24-2C up front because I want to sample the macula. If the central points are normal, but the 24-2 is abnormal, I'd follow with a 24-2. If the central points are abnormal with a C, then I might switch to a 10 and almost use that as my predominant visual field. But it's a tough call, and I think we have to continue to watch the literature to see what else continues to come out regarding 24-2C and similar algorithms that may come out from other companies.
And I'm going to add to that. I do a lot of glaucoma in my practice. It's probably 50 to 60%. And going to the OGS, listening to Rich talk about this I think I heard him talk about this when I was in New York at a different society. I was there lecturing, he was lecturing. If I do a 24-2 and it is clean, but I have an OCT that's showing a defect, I will do a 10-2. I kind of take it like, okay, maybe I'm missing some points. There's some macula that's involved. So, if I have a ocular hypertensive that I'm following and I'm looking at the N snit, the T snit, all the different cuts, looking and segmenting, and everything looks perfectly clean, I'm not going to torture them and do a 10-2. However, if I got defect on an OCT and my 24-2 doesn't seem to be matching what I'm seeing, I'm running a 10-2 and that will sometimes
I think that's
surface.
a great point. I really think that's a great point. And it comes with experience. You're an experienced clinician with glaucoma. You know that your OCT is telling you something is not normal, yet you're not finding anything functionally it makes sense to dig in a little deeper and you may come up with something. That's an excellent point.
Let
And
me
I
throw
think,
this question out to you
sure.
real quick. This is not
Yeah.
in the chat box, but if you have the macula involved, are you treating a little bit more aggressively? Are you trying to get their, making sure they're at their target IOP? Are you following them more closely when the macula is involved?
Yes, and
I can
yes, and
tell you, I do. I've done
me
many of
too.
them. Okay.
Absolutely, I do. If you just think about the fact that, what's going to have the greatest effect on quality of life is is damage to the visual field closer to fixation. So reading vision, those sorts of things, facial recognition. Yeah, so I am going to treat those patients. And with some of the newer data telling us that loss of central points or defects centrally also predict greater progression more peripherally, there's just even more reason to treat more aggressively when the central visual field or the macula is involved. So yeah, I agree 100% with what you do.
So driving this home to the audience is, why are we talking about recognizing glaucoma as a macular disease? It's just not macular degeneration. Glaucoma is a macular disease, and when the macula is involved, the vision's going to, that's the most central part of our vision. We're going to treat a little bit more aggressive here. I do tend to follow them closer. I do tend to make sure that they're at their target pressure, or maybe even set their target pressure maybe a little bit lower. So
Lower,
that's
yeah.
the clinical significance of what this whole discussion here. All right, no problem, Leslie. Leslie said she took it down because we kind of answered it. No problem. I just
Great.
thought I saw it
No,
there. And then we have another one. How many let's see, how many 10-2 visual fields will you perform per year? And will you also perform OCT, optic nerve head, at the same time?
well, yeah, let's start with the structural part. No question, the patient's getting OCTs. Um, and it's funny because I think we all recognize that since the advent of OCTs, we don't look at the optic nerve as critically as we might have in the past, but certainly we'll get photos periodically. I always try to look at the nerve, or have one of my students or residents look at the nerve every visit, even if they're undilated, just to see if they have a Drance hemorrhage or not. But we're certainly doing structural testing. In regards to the number of 10-2s, hard to say. It really depends on the extent of the damage that's already there, the age of the patient, what I predict the patient to how I might predict the patient's progression going forward. And it's really no different to how many 24-2s. Now, we do have information from a number of studies that probably we need at least 6 24-2s over the first 2 years to give us a good sense of progression, I'm sorry, to detect fast progression, which is about 15% of glaucoma cases. And one of the areas of research, and I think I'll probably bring this in the next time I do this course somewhere, is to consider the fact that we need to identify ways in which we can find or detect fast progressors faster than 2 years, because those are patients that need to be treated aggressively. A very interesting protocol that comes out of Australia is the whole idea of front-loading visual fields, doing two, and they use 24-2Cs, doing two 24-2Cs at the first visit, and then doing it again, let's say 3 or 4 months later. So you're getting to a baseline faster, and they're showing that they can identify fast progression quicker. And there are a number of different, that's not the only approach to this. So it's just something else to think about. So this is really an active area of research. And if you are seeing a lot of glaucoma patients, I urge you to try to stay on top of this and try to give you a better idea of what's the best approach to some of your patients. It's a very interesting area to me.
And I'm glad you led off with this because I think a lot of us are getting away from visual fields, and visual fields should be done as often as OCT. So that was great, and I'm very glad that you
Yeah, I
started
mean,
off
we
with
we
this.
can't forget, we cannot forget fields, although data tells us that the number of fields being done has decreased precipitously since OCT's advent. So don't forget the fields. Yeah, they're a pain, but they need to be done. And another thing to discuss, and again, we won't do that tonight, are virtual visual fields. So that's probably the next go round on some of this, but I don't think any of those are, they're getting out there, but I think, maybe need a little more development. But I don't know, Greg, do you use any of those?
Yeah, I had the first generation when they were out. I think they have their place in time. The second and third generations are coming out. And then I think what's going to happen is they're going to add in all the other pupils and VAs. And I'm kind of
Agreed.
envisioning that someone's going to walk in someday. Is this your insurance? Okay, put this on. And then it's going to get uploaded. But I think that's the time to come.
All right.
So Rich, you're all caught up on the questions. Let's
Great.
move on to the next
So
topic.
this is great, and the discussion is wonderful. So what I think, if it's okay with you, Greg, and again, I apologize for you having to look at the side of my head. I think this is the better side too. I'm going to skip the next section because I have a lot of stuff, and
Okay.
I want to get to the things that I think are kind of probably be more useful at this point in time for the audience.
Okay, whatever you want to do.
So
I
the
might
next
have
part
to
was on.
adjust your post-event survey questions, but
Oh, okay, then we can go through this quickly. So essentially, this is the role of OCTA in glaucoma management. And a lot of you have OCTA on your OCTs, whether you know it or not. And OCTA has been shown to be useful. So to cut to the chase a little bit, essentially the way it works is you get sequential B scans done in the same region of the retina, and anything that moves from scan to scan has to be red blood cells because they're the only thing really moving, and those red blood cells then tell us where the blood vessels are. And so you get an angiogram that looks at the different layers, and again, I'll go through this somewhat quickly because I think we can get to the point here, which gives us a sense of the choriocapillaris, which of course feeds the outer retina, the photoreceptors, and then the deep and superficial capillary plexi, which feed the inner retina. And so you get something that might look like this, which shows you all of the vessels, but what you can do is click on any of these boxes. And again, each of the instruments from different manufacturers are slightly different. But this shows you the vitreoretinal interface where we would expect no blood vessels, the superficial capillary plexus, the deep capillary plexus, what's called the avascular area, which is essentially where the photoreceptors are. We're not supposed to have any blood vessels there, and then down into the choroid. And these can all be put together to give you an image that looks like this in color or in black and white. So the applications in glaucoma are essentially all of the areas where there's blood vessels in the retina. Of course, most importantly, the disc and peripapillary region. But as we've already said, the fovea is involved in glaucoma as well. So there are numerous parameters. We won't really talk about any in detail because that would really extend our time. But there are numerous parameters that could be looked at. And probably all of them have been in some way studied to show that there are changes in glaucoma. So these are all fairly old images to show you that we've been looking at this for a while. But here, for instance, is a patient. If we look at the blood supply to the optic nerve head, we can see that here's a normal, and here's a patient with pre-parametric glaucoma or glaucoma damage without visual field loss. And you can see this rather large area of poorly perfused optic nerve. So these are always difficult patients, these pre-parametric glaucomas. And this may be another bit of information that might help us in determining whether the patient actually does have glaucoma. So there's a great paper back 2016 showing a normal, a patient with some early damage inferior and a field defect that goes with it. And then notice the density of vessels as they start to decrease, worse inferior, but now you're starting to see change superior. And then down here, more advanced or severe disease right over here, where you can see there's this dense superior defect, but also a beginning inferior defect as well. So that's the parapapillary area. We even see change in the macula. That's not a surprise based on our discussion before. So we have normal on the left and the different layers, superficial and inner, and they added an inner layer here in deep, puts all of these plexi together. But here's a patient with a arcuate defect extending into the macula, which goes hand in hand with this inferior defect. And on the OCTA image, you could see that there is a big difference between the normal and the glaucomatous over here. Even foveal avascular zone, which we've always looked at in diabetes as increasing in size in diabetic patients, but here we see it. An increase in size of the foveal avascular zone in this patient with normal tension glaucoma. And here's advanced glaucoma, where you could see a very large dropout of the vessels within the retina. And this just showed progression. So there are other considerations with OCTA. I think it's going to help us and look for progression in those subtle cases. It has been shown to be helpful in high myopia in differentiating myopic glaucoma from just healthy high myopia, as this particular slide says. And that would probably be something that would be a much longer discussion. And I think some of you are probably familiar with the floor effect on OCT, where the OCT cannot measure any further loss of thickness of the retinal nerve fiber layer. Well, the floor effect appears to disappear on OCTA, allowing us to follow patients with OCT who have more advanced disease. So, OCT, essentially what this slide is saying is that OCTA is probably useful and will become more useful in managing glaucoma, and AI will help us look at some of these images and get a better sense of what these images are telling us. The current issues with OCTA, there's a limited normative database. It's affected by other vascular diseases and other eye diseases. It adds time to imaging, and time is always important. But to me, probably the biggest one might be there's no consensus regarding nomenclature of scan protocols between different instruments. And that will change over time as we gain more information regarding OCTA. So that's really, I think, all I need to say about that. I think it's something that's there. I think I use it not that often. I think probably if we want to learn more about it as clinicians, we should probably do it on everybody, because that's the way we'll learn. But it takes time, and time is often the thing we don't have in our busy offices.
Thank you.
Greg, anything else on that?
No, I mean, I have OCTA. I like it in the office. I think you summed it up. It helps me with the progression. It is a little bit trickier because the patient has to be really good at holding their eye still, because a little bit of movement can really mess that up. But
absolutely.
quality is an issue with OCTA.
But I think it's something that, down the road, we will find that it becomes more useful. All right, so let's move on. I think this is probably the biggest issue most of us have in our offices right now. Patients don't take.
We got a couple questions here.
Sure, of course.
Let's get them cleaned up here. So back to the 10-2, it says so many glaucoma patients have macular issues, macular degeneration, epiretinal membranes, lamellar holes, PVDs, blah, 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 which can all affect the 10-2. How do you sort it all out?
It's, you may not be able to. Yeah, you may not.
Exactly.
Yep. Right. And it's the same thing with macular OCTs. They affect the macular OCT as well. Yeah. So if a patient has concurrent macular disease, all bets are off here. And you just have to try to sort it out the best you can. And you may not be able to follow the central 10 degrees to look for progression or even make your diagnosis. You may be looking at it by looking at the circumpapillary retinal nerve fiber layer in the 24-2 as opposed to the macular OCT in the 10-2.
You chatted about this in the question that came in. You chatted about this. We want to identify those fast progressors out there. Is there anything systemically linked to these fast progressors like thyroid or sleep apnea or any other
Yeah, that's a
condition?
very good question. And the answer is yes. Um, Boy, that's kind of a big question. Sleep apnea probably is one. Um, Hypotension, systemic hypotension, and systemic autonomic dysregulation are associated with faster progression. Yeah, there's a number of systemic conditions that are associated. And again, yeah, that at least helps you, if not identify the fast progressor, because the only way to identify a fast progressor is by seeing that they are a fast progressor. But it certainly clues you in as to which patients may be fast progressors, and therefore you may treat them either more aggressively or watch them more closely, as Greg said before. That's a great question. Yeah.
Yeah, I think, I've been taking a lot of functional medicine courses. Obviously we all grew up in allopathic, Western medicine. You have a sty, you treat an antibiotic at its opposite, you cure iritis, steroids. I think when you come to these fast progressors, I think, Tina, you're hitting this, is that there's times whenever, end organ damage from disease, right? We see it in diabetes as in kidney disease, or we see it in retinopathy when it affects the eye. I think these fast progressors are just kind of unfortunate that they have glaucoma, but yet there's something systemically just adding more fuel to that, creating that to become a fast progressor. So, yeah, I think, it's just not primary open angle glaucoma that just happens to be fast progressing. A patient's allowed to have as many diseases as they want, and they're
Yeah, and I
just being
throw in the
added.
genetics as well.
Exactly.
And plug, I think I'm back in 4 weeks or so, and the topic is systemic diseases and glaucoma. So we
Boom,
might
boom,
have the
boom.
opportunity to discuss this very topic. So thank you for that question, because it's a good one.
All right, one more here, and then we'll let you move on. Here
Yeah, sure.
is
Hey,
in
this is
in
fun.
the case of increased foveal avascular zone increases in glaucoma patients, was this separated from those who had diabetes? So, in other words,
Yeah,
do they have only glaucoma and increased foveal avascular zone? I'll let you answer that, and then
I
I'll take a
I
crack at
don't
it.
have a good answer. I'd have to go back and review that particular paper. If they didn't, then yeah, it's almost impossible to tell. So I'd have to guess. Again, I haven't looked at that paper in a while. I'd have to guess that they separated out the diabetics, because yeah, diabetics have increase in the size of the foveal avascular zone. Yeah, so I
I mean, I
really
have
have to review that
OCT
paper.
angiography, and when I do the macula and I'm looking and following it for glaucoma, I'm not really looking for an expansion or that distorted foveal avascular zone in the glaucoma. To me, that's not the pathophysiology of the mechanical side of where this disease is. It's more of that capillary density of the macula, the thinning out, rather than that foveal avascular zone. So,
I think that's what
uh,
most people are looking at now. First of all, it's the easiest. I mean, you can kind of you get it, you can almost eyeball it many times. Yeah, but it is in the literature that the foveal avascular zone is involved. We'll see where that goes. But I think it's a good question, because yeah, diabetes, and there's a handful of diabetics out there last I looked. It's really going to complicate things.
yeah. All right.
Good, great
Caught up, my
questions.
friend.
All right, so let's move to the next. This is no surprise. Patients don't take their medications as directed. Who knew? And you even have a group of patients who try to take their meds, but they can't properly instill them. So it's important to remember that. And of course, these problems lead to poor outcomes, increased complications, increased healthcare costs. There's no big surprises there. See Everett Koop, the Surgeon General of the United States in the late 1980s, said it best: drugs don't work in people who don't take them. How profound that is. Now, we've actually had the opportunity to quantify some of this, in that if you're familiar with the SIGIT study, Collaborative Initial Glaucoma Treatment Study, which came out 20 or more years ago, this is a follow-up 20 years down the road, or 18 years down the road, actually quantified how important adherence is. And essentially what you're seeing here is now this is patient self-reported, but it's probably in the ballpark, where some patients said they never missed, then a third, a half, and two-thirds missed. And you'll notice that for the people who said they never missed, they lost over the course of 8 years about 0.62 decibels of visual field on the mean deviation. And those that missed two-thirds of the time, or reportedly missed two-thirds of the time, they probably missed more than that, had about 4 times the rapidity of field loss. So this is one of the few times we've actually been able to actually quantify the effect of poor adherence. And as a patient, I've reported on a number of different places, but she was just so interesting to me. She came to me for the first time with red eyes. She had advanced normotensive glaucoma, and look what she was on. I mean, to summarize it, in addition to her SLT, she was on 4 bottles. She was on 3 installations in her right eye and 6 in her left, with 3 active agents in the right and 4 active agents in the left. So how could she adhere to this? Her eyes were red from the active agents and all that BAK we were pouring into their eyes. So we can do better than this. And that's really what this next section is about. It's taking the patient out of the equation, but also making it easier for the patient to adhere to what we're doing. So we're going to talk about improving IOP lowering by removing the patient the best we can from the equation via laser trabeculoplasty, intracameral devices, and MIGS procedures. Polling question number 2.
All right, the question is open. And what percentage of my patients do I recommend SLT as the first-time treatment? For those having trouble finding it, if you just want to put it in the chat box, that's totally fine. So what percentage of my patients do I recommend SLT first time? 0, 25, 50, 75, or 100%? So are you using SLT as a first-line treatment?
And you can take recommend any way you want.
And I'm going to check out the chat box real quick. We are caught up in the chats. And let's get back to the polling. And all right, we got a nice sample of people already rolling in here. So I'm going to display the answer. And Rich, pretty spread out, 0% is 30%, or 0 is 30%. And then 25 is 33, and 50 is 17, and 75 is 12, and then 100% is 9. So obviously, kind of your, go ahead.
I think that makes perfect sense to what we see out there. And I think if we asked this question 10 years ago, we might see almost all at 0% as first-line treatment. So that's great, because I think this is something that's really evolving right now. And didn't we ask this question at OGS? Asked a different way, I think, which is, I think the question was, what percentage of your patient? No, it was asked just this way, I think. And I don't think the results were that different. So the question is, should SLT be a first-line treatment? Unquestionably, over the last few years, we're seeing a greater number of first-line SLTs. We're also seeing it used much earlier in the course of the disease. At SUNY, we are doing way more SLTs than we did even 10 years ago. And as many of you are familiar with, one of the things that's really changed this is a study called the LIGHT study, which was done in the UK. And it's interesting because some of the information or some of the conclusions from the LIGHT study were not that different from the glaucoma laser trial, which was with ALT in 1989, or the SLT med trial done in 2010, both showing the efficacy of laser as first-line treatment. But they did more in this study, and I'll go through that quickly. So this is the LIGHT study. It was published in the Lancet, which is a major medical journal, not just an eye journal, telling you the importance of this paper. So again, it was performed in the UK, and it's important to remember that, of course, because the UK has a national health service. So there were 652 patients randomly assigned to SLT or eye drops. And as the slide tells you, 74.2 of the SLT patients reached their target IOP and were drop free at 36 months. So we've, in some ways, removed the patient from the equation. There were 5 times less drop-related adverse events with SLT. And if I pull myself back over here, interestingly, the quality of life was actually the same between the groups. But my opinion and the opinion of others is that they probably used not the best quality of life survey, because patients who use drops are not going to have as good a quality of life. The data is the data, but I think the survey may have been the wrong survey. And SLT was shown to be, after about 30 months, to be more cost effective than drops. So clearly indicated the efficacy of SLT as first-line treatment. And in fact, because this is the UK and they have a national health service, the statement was made that SLT should replace drops as first-line, or should be offered in place of drops as first-line therapy. Now, in the US, with our amalgam of insurances, we're never going to see that type of consensus. But this has really moved the needle quite a bit in terms of first-line SLT. So just some follow-up from this study. This has been some great data that's come out with it. So just go through it. A slightly larger proportion of medically treated patients had rapid field progression as compared to those treated with SLT. That's probably because SLT flattens the 24-hour diurnal or circadian IOP curve. And there have been other studies that have shown, either with stents or other MIGS procedures, have shown the same thing, that even with similar IOP reduction, the patients with the medical procedures as opposed to drops do better. 70% of those in SLT group remain drop-free at 6 years. SLT is a safe treatment, providing better long-term control and reducing the need for glaucoma or cataract surgery at 6 years. SLT as first-line treatment showed a 29% slower visual field progression rate compared to glaucoma meds. And the last one is important, I think. This was actually done in what's called the Light China trial. So this was a kind of a done in China, but actually using the Light protocol. And repeat SLT was associated with similar IOP control to initial laser with longer duration of effect in the Light China trial. What that is saying is that regardless of the response to the first SLT, repeating the SLT was really a good thing. What we have, most of us, I think, if we send for an SLT and we get a poor result, we move on to something else. This is telling us, do the SLT again, and you may be very surprised at how well you do. So a lot has come out of this Light trial that helps us make the case for first-line SLT or very early SLT. Now, just taking this a step further, and I think this is really important because this has, I think, a lot of implications in the healthcare system. Just trying to move our faces a little bit here, Greg. So this is in the
as you're moving, I put a question in. I'm curious. Are there any optometrists out there that can do an SLT? So Rich, keep going. We're gonna let that polling question run. Please go to the polling question. I created that.
Oh, okay.
I just wanted to see if any. You keep lecturing, Rich. I'm just
yeah,
gonna let that polling question.
I would have. Yeah. So we're going to see who the Oklahomans are here, huh?
Yeah, exactly.
So this is an interesting one, and I think optometrists should be aware of this. So you see the title, a proposal for the use of a fixed low energy selective trabeculoplasty. And essentially what these authors said was, the SLT energy has kind of been titrated from person to person over the years. Pigmentation, a lot of high energy, et cetera, et cetera, et cetera. Spot size was bigger in SLT and so forth. But the point being made in this paper was that essentially low energy, kind of the same for everybody. So we're not getting into all of these different permutations on how to utilize the SLT. And I want to call to your attention the last author of this patient, Michael Belkin, an Israeli ophthalmologist, and we're going to come back to him in just a few moments. So this is a study that is going on right now, and I think it's an important one. It's called the COAST trial. And in the COAST trial, it's a randomized trial, 635 treatment naive patients. And there's kind of two pieces to it. One is the standard versus low energy SLT. In other words, what those authors said before. Let's try low energy SLT versus the higher energy, and slightly different from patient to patient. And they'll look at the 12-month success rates. But in addition to that, at 12 months, patients undergo repeat SLT either annually at low energy or as needed at initially assigned energy. In other words, the way we do it now, and we'll look at it at 48 months. Essentially, what this is saying is should we consider in our glaucoma patients doing SLTs at low energy on a yearly basis? And so I think this will be very interesting at the end of the day, because we may find that doing low energy SLT yearly may flatten the IOP curve, give us better visual field results, and reduce the need for drops and all of the side effects and things that go along with drops. Let me add one other thing, and then I think we can discuss some of this. So I mentioned Michael Belkin before. He has developed a laser called the direct SLT, which was cleared by our FDA in last December, and has been available in Europe for a while. So what is the direct SLT? Well, it's 530 nanometers. It's been cleared. And essentially what it does, and I can blow this up here, on the left-hand side, you see the standard SLT. So you need a gonio lens, and the light goes through the cornea, and it comes here into the trabecular meshwork. With a direct SLT, the energy is actually given outside the cornea, so it goes through the limbus and hits the trabecular meshwork from the outside, so you don't need a gonio lens. So this is kind of what it looks like. It looks like in an autorefractor. You get 100 spots. Okay, the image processing algorithm locates the exact treatment area. So it's really a press of a button, 100 laser beams directed at the meshwork, and then you get your SLT effect. Simple. I mean, SLT in and of itself is not a terrible, if you can do gonio well, you can do an SLT. But this is if you can press a button and align a patient, you can do a direct SLT. So this has been studied and not published, except, well, this was actually a publication in the British Journal, but not the final results yet. This was laying out the Glorious trial, as it's called, but there have been some ARVO abstracts, which essentially show that direct SLT and regular SLT are similar in IOP reduction, similar in lowering the number of medications, in other words, similar with no safety concerns identified. And I'll mention, I don't think I put a slide in on this. I did not. But it should be mentioned, I think, that Alcon has bought this direct SLT. So now you've got a big company, a big eye care company in the United States who now own this laser. So I think, this could become a very, very big player because of the speed and simplicity of doing this procedure. And I'll end before we move on to discussion. I'll just end with this. Every time I talk about this, I think it comes home to me that if we're going to do more SLTs, more first-line SLTs, or maybe we're going to do them yearly on the patients, and we're going to have this easy direct SLT, who's going to do them? I mean, the glaucoma specialists, their numbers are shrinking. They're incredibly busy. It would seem to me, and obviously our state laws will affect this, but optometry seems to be the perfect purveyor of SLTs. And again, I practice in New York. We just got orals. So, let's, I gotta look at this carefully. But notice in the UK, in Eye and in Nature, you see that they're very carefully looking at using optometrists to provide SLT because of the efficacy of the procedure and the number of SLTs that are being done. So they're kind of out front of us in regards to optometric use of SLT in glaucoma. So that's my shtick on SLT.
So we had some questions roll in as we thought. Are the U.S. medical insurances very receptive to SLT as the first line RX?
Yeah, I think in most cases we don't see any problems in getting SLT as first line therapy.
I do sit as the third party chair for the
Yeah,
PLA.
so you may answer that better.
Yeah, and I can tell you, like, there doesn't need to be like a prior authorization or a failure on a med or anything like that. And so the answer is yes, it's very well received, at least in the states that I have worked with. So I think
Yeah.
that's pretty globally. So,
I agree.
when you talked about the light study, was it for primary open angle, or did they include any pigmentary glaucoma?
Yeah, they did. They did, but it's essentially open angle glaucomas. I don't remember
Perfect.
the numbers off the top of my head.
Yeah, we just chatted about it, and I looked it up while I was sitting in the audience, and it was mainly the majority was definitely primary open angle. And then I did put that polling question out there. Someone's asking if it's number 3. The answer is no. I just created it on the fly. We have 23 responses. No one is able to do SLT. I think there's 13 to 14, 15 states now that can do it.
Yep, we're getting
Um,
there.
Yeah.
We
But
have
none of the
a
audience, but there's only
course
been
at
23.
SUNY. I would assume most of the schools have a course of some kind in performing SLT, but in each of the states, of course, you've got to actually go in, and I think in every state you've got to go in and get certified, which I think is a very reasonable approach to things. But we have all of our students are exposed to practice eyes, and they do an SLT.
I have an Oklahoma license. I went out actually. I took the course that was given by Nate Lighthizer and
Yeah.
his Oklahoma crew, and I was actually more excited about kind of the radio frequency, the Elman unit, and all that stuff. So it was right up against the time whenever it was fresh. I took the course 6 weeks later. Flew to Oklahoma. It was great. It was with all these little young kids and 20-year-old, and I took the state board, and I continue to carry my Oklahoma license in
Beautiful.
hopes of someday being able to do SLT.
It's not. Each day it's becoming less and less of, or more and more of a possibility, I guess I should say. But it's very interesting what they're doing in the UK. I mean, they're not messing around with this. We always think we're way ahead of everyone else in the world in regards to the care we provide. And in many ways we are, but in this particular case, we're not. And I think part of that, is having a national health service, which is going broke, but that's a different story and a discussion for another day.
Well, I'm going to close this polling question. We had 62 of our participants say that they don't do SLT, but we have one that's able to do SLT, which is fantastic.
Yeah. Okay. And hopefully we'll see those numbers change. But clearly, in the last few years, there's no question. And I think the data supports earlier SLT for so many reasons. Better 24-hour control. I mean, the studies seem to indicate that. less medications, less BAK onto the eye, less patients involved in their care. All of those things I think are very important.
And the medication itself, both the inactive and active ingredients,
Absolutely.
if you want to say, numb or desensitize that trabecular meshwork, where you actually get a better result in kind of more of a virgin type of trabecular
No,
meshwork that
there's no
hasn't been hit.
question about that. It's a great point. People think that BAK only affects the ocular surface. It affects the trabecular meshwork. So yeah, great point. So let's take this a step further and look at a couple of other things that are being done to reduce the medication burden in our patients and to take the patient out of the equation. We now have a couple of intracameral devices that are available. One has been around for a while and one is new. So some of you may be familiar, and you can, I'm going to pause it for a second so I can say a couple of things if I can actually get it to pause. It means I got to stop the laser pointer. Oops, the laser pointer is still going. There we go. Then I'll run it back. Let's bring it back here. Bimatoprost intracameral insert, or Durista, was actually approved the first week of the pandemic. So nobody knew it happened for a while, but it was approved when the pandemic started. This is intracameral bimatoprost 10 micrograms insert. It's a sustained release biodegradable rod-shaped implant. It's a pellet that's placed into the eye, into the anterior chamber. Gravity pulls it down and it sinks into the inferior angle. And over time, it degrades and it's slowly releasing bimatoprost. And the bimatoprost is essentially gone in a few months. But as we'll discuss in a few moments, it actually has a much longer lasting effect. So let's just look at it. So we're entering the anterior chamber, and you can see the pellet at the end of the inserter, and then you'll see it just fire out there when the plunger is pushed. Boom, there it goes. So that's the pellet. And okay, that's the end of that one, but we'll go here. And that's what it looks like as it sits in the anterior chamber. It usually falls inferiorly, not surprisingly. And this over time will disappear. Now, in the clinical studies regarding this, patients could have multiple pellets in their eye. As I'll mention in a few moments, the FDA has only approved one of these, so you would be doing this off label if the patient had more than one in their eye. So the Artemis trial was the randomized trial, the pivotal phase 3 trial that got this thing approved. And essentially, IOP was controlled similar to bimatoprost drops, or the primary endpoint in the, as with most FDA trials of medications, the non-inferiority is to timolol, which is an easier comparator and is the typical comparator. But essentially, it showed the efficacy of this. But as mentioned, let me just go back. As mentioned here, this long-lasting effect. Even though the medication is essentially out of the anterior chamber after, let's say, 4 months, a fair number of patients, up to perhaps even 40% in the study, have significant IOP reduction out to 2 or 3 years. So the question is, if the active agent is gone, why is the IOP lowered? And although I don't think this has been fully shown, if you think about how prostaglandin analogs work, they change the anatomy of the uveoscleral outflow system. So you might anticipate then that this slow release of bimatoprost over the course of months might have a more lasting effect on the uveoscleral outflow system. So that's one of the things that's thought about. But think about that. you could put one of these in and a patient may not need drops or may need fewer drops out to a couple of years. So there have been some more recent studies, so-called real-world follow-up studies that have come out this year. So just to show you, durable IOP control up to 13 months and reduction of topical meds, IOP lowering well-maintained for greater than a year in the majority of patients, 40% of eyes with medication reduction at 12 months, a single implant effectively lowering IOP. So more to come on Durysta, but it appears to be an effective medication that reduces IOP for a period of time while also reducing the medication burden on our patients. So this is just their, that's a slide from the company. It's limited to a single implant per eye. You can see the size of it. It's pretty darn small. As with any anterior segment procedure, be careful in eyes with low corneal endothelial cell counts, and that's very important to the FDA after the Alcon pulled the CyPass from the market a few years ago. Same contraindications as with PGA, so you have to worry about cystoid macular edema and uveitis, and don't use in narrow angles. So that's been out a few years, and we're just starting to see an uptick in its use that may give us a better sense of how this is going to fit in. I think you get the idea that this is probably going to be best for patients who will tolerate an injection of something into their eye, who perhaps can't put drops in, maybe they have rheumatoid arthritis, or they can't comply with our instructions. The new kid on the block, and you can see it was approved 12/14/23, and we're just starting to see it come about, is the iDose TR, the travoprost intracameral implant. And this continuously delivers very low dose travoprost for extended periods of time. But this one's different. It's not a pellet that sits in the eye. It's actually a titanium device with a little canister that holds the medication. It's anchored into the trabecular meshwork and through to the scleral wall. So it's a different type of device. The thinking is the same. So here's what it looks like. And you can see, kind of how the device will sit and be placed through the meshwork and anchored into the sclera. Here is the anchor right here, and so forth. So, there's a button and so forth and so on. But the bottom line is you get the canister here, which slow release of travoprost at microdose levels into the anterior chamber. So let's see what that looks like, if this will go. Come on, baby. Okay. Let me see if I can get rid of the lid. Yep, that's what I needed to do. So here it goes. So you do need the gonio lens. So the degree of difficulty is definitely greater here. You're not just firing a pellet into the eye, but you can see it's anchored into the meshwork and then into the scleral wall. That's how that works. Oh gosh, I didn't mean to do that. Jeez Louise. Let's go back to here. Sorry about that.
As you're doing that, Rich, a question did come in.
We're back, yeah.
Okay.
Yep. Go ahead.
Finish up this section. It's about SLT.
Okay, yeah. Let's finish the section and maybe we'll pull them both together. The wrong button there. We got everything though, right? We're good?
Yep, just go to PowerPoint mode.
Yep, there we go. That's what we need to do. Fabulous. Okay, and this was the randomized trial. Essentially, again, the comparator was timolol. The one that came to market is the slow release dose. And you can see here that the IOP lowering was significant and better than timolol. Again, that's what most FDA studies compare to timolol. So you had significant IOP reduction between 6.6 and 8.5 millimeters. At 12 months, 81% of the slow release subjects, that's the one that's on the market, as I said, were completely free of IOP lowering topical medication with excellent tolerability. And here is the adverse event profile. Slightly more adverse events than timolol, as expected with a prostaglandin. But remember, this thing is micro doses released in the eye, so no effect on the ocular surface. Very, very few side effects. You get a little more iritis, not surprisingly, again, because of the prostaglandin. But the difference here is, unlike Durista or the bimatoprost device, where there was no active agent measured in the anterior chamber after a few months, after about 18 months, there's still about 20 or 25% of the travoprost still remaining, still being microdosed into the anterior chamber. So it's a different kind of device. Okay, so I think the next slide is a polling question, so we could stop there and maybe go back to the questions.
Yeah. Let's see, which one is it? The polling question number 3, yes. All right, I'm opening up polling question number 3, and it is, in the last year, what percentage of your glaucoma patients have you recommended MIGS procedures? And with that being said, 0%, 25, 50, 75, or 100. The question that rolled in, Rich, was basically, can you repeat an SLT, is what it came.
Yep. And the answer, of course, is, yeah, of course you can. It's whether it's effective or not. And I don't really want to be facetious, so I shouldn't have been facetious, but and I'd like your opinion on this too, Greg. I think most of us have always felt that when you repeat the SLT, you're going to get a diminished effect. I think that's probably been the word on the street. That recent data from the China Light study has cast a different eye on that and seems to indicate that maybe that's not the case. Now, that needs to be repeated in other studies. But you can repeat an SLT. Whether I guess the question on now is, do you get a similar response? Do you get a better response? Probably not. Do you get less of response? One thing I think you always have to think about, and I think this is one of the reasons SLT suffered over the years, is we often did SLT later in the course of the disease. We'd fail on 2 medicines or 3 medicines. And the lower the intraocular pressure, the less effect you're going to get from the SLT. So I think we were always looking at SLTs. We would do it when the pressure is 15 and the patient's on 3 meds, and you'd get to 13. And then, what would be the point almost of doing it again? If we do SLT earlier with higher pressures, we may find that we get a better effect, not just of the primary SLT, but the secondary SLT. So the answer to the question is, yeah, you can do it again. But what will the effect be? I think it's really going to depend on start IOP, the extent of the disease, how many meds the patient's on, and so forth.
And I think a way to look at it is kind of what you just highlighted with the Durista and the iDose, is that when you take away all those inactive ingredients, I mean, you put talking to the MSL, the medical science liaison, I believe Durista is one, in that micro pellet, is 1 drop of the 0.3%.
Right. It's the old, yeah.
It's 1 drop. It's 1 drop that is slowly released over whatever time, and then you have those effects out to a year. So I think, when we use, of the Durista. And so when I talked to the MSL, I said, how many drops are condensed in there? And he said, it's literally just 1 drop. So I think what we're highlighting is, I think it's a catch-22 when we use bottles. We're putting the medicine in. It's hard to get the medicine across. These prostaglandins, the Travatan and the bimatoprost, or the Lumigan, is more of a lipophilic. The other ones are esters. It's hard to get it into the cornea, so you're bypassing the biomechanics of the cornea. You have all the different preservatives that are out there. And then, like you said, I think you kind of have to study each patient. It's not, can it be repeated? Can it be repeated in a eye that's never had an eye drop? I think you'll get a better effect than one that's been hit with all these different drops. So I think we're going to have just more uncovered as we go through here. So
And I think you made a very good point too about it's individualized. When I first started treating glaucoma, we had timolol, pilocarpine, propine, and then off to ALT or surgery and maybe carbachol in there. And we kind of treated everybody the same way. It was one size fits all. But I don't think that's the way glaucoma should be handled. And I certainly think we're heading in that direction to completely individualizing the care we provide to our glaucoma patients. And I think you made that point well, Greg.
So here's a question that came in. Can you do an MRI if they have that that iDose canister, titanium canister?
Yeah, I believe you can, because it's not a metal type of thing. But you know what? Geez, I took a whole course on this, and I'm not remembering the answer to that. You know the answer to that one, Greg? I
Yeah,
believe you can.
I
I don't
believe you
believe that.
can. I'll
Yeah,
Google it real quick while you're
yeah.
chatting,
Would
but I
you?
think the
Yeah,
answer I believe is yes. But I'll fact check that while you're lecturing.
yeah.
So
Because that
your
would be bad information to have wrong.
polling question is with regarding your MIGS. 0% is the leader at 49%. 25 is 35%, and then it drops when you get to 50,
Yeah,
it goes to 11, and then 75 is 5, and then no one is going 100%. So
yeah. Okay. And that's not a surprise, but hopefully we'll start to see that change to some degree. So, which patients should have MIGS? Just a quick, I mean, there's so many courses out there about MIGS procedures. Um, I just realized something. I thought I had a slide in a different place, but that's okay. Um, that's odd. Anyway, microinvasive glaucoma surgery, minimally invasive glaucoma surgery. The name has changed, but essentially these are procedures that facilitate outflow to reduce IOP. Normally they've been done ab interno, which is less invasive, but now you're even starting to see some of these being done ab externo coming in from the outside, which are more invasive, and some are even with the Zen gel stent, for instance, which is actually a bleb type procedure. And it brings us to the concept, or we'll talk about the concept of interventional glaucoma management. But before we do, let's just remember why we need MIGS. It's not just to reduce IOP. You want it to be efficacious, but I've had patients with pressures of 12 get a MIGS procedure when they got cataract surgery. Why? I wasn't thinking I was going to lower their IOP, but reducing the medication burden is just as important. And if you look at any of the studies on MIGS, the secondary outcome is always the number of meds the patient is on. And that increases adherence, it reduces cost, spares the conjunctiva and cornea. So although you may be delaying the time for higher risk surgery, sparing the conjunctiva and cornea will increase the success of those procedures. Now, we're not going to get into which MIGS procedure. There's a number of questions that could be asked, and we'll just go through that quickly. But this is a slide that's about 4 years old now, 5 years old now. But the landscape hasn't changed all that much. On the left, you have the MIGS procedures, which include things like the iStent, at the time iStent inject. Now you have the iStent Infinite and the Hydrus. So these are non-bleb forming. We don't have any suprachoroidal devices at the moment. We have those that cleave tissue, like the trabectome or the Cahook dual blade. And we've got these bleb forming procedures as well. We also have those that dilate Schlemm's canal. So the bottom line is, and on the right you have traditional glaucoma filtering surgery. The bottom line is with MIGS procedures, you know, obviously it's going to come down to which procedure your surgeon wants to do. But I think it's important for us as optometrists to know about the procedures. Like, I wouldn't want to send a patient with mild glaucoma who needs cataract surgery and have them get like a Zen gel stent. I mean, that's crazy. It's a relatively invasive procedure. Those patients are going to do well with things like iStent Infinite or Hydrus. So I think it's important that we know and can explain to our patients about these procedures. And it does bring us to the concept of what's called interventional glaucoma management. And you could read it, but it's essentially a glaucoma treatment strategy aimed at changing the course of the disease in a customized, back to what Greg said before, customized approach for each patient. MIGS procedures provide many of the benefits needed for effective interventional management. We had a discussion at one of the side meetings at OGS about what interventional glaucoma management means. And to many people, it just means early surgery. But it's not really that. It's early intervention that may utilize MIGS procedures, but also SLT or even some of these drug delivery systems that we talked about. And it should involve or can involve standalone interventions not related to cataract surgery, because many of the MIGS procedures have needed cataract surgery. And it also speaks to using predictive diagnostics, using all we know about OCTs and visual field to guide our treatment. So again, earlier use of MIGS procedures and laser trabeculoplasty, as well as the Duristas and iDoses, to achieve the goal of changing the course of the disease, to be proactive, particularly in those patients who require aggressive treatment. And if we're using drops and continue to use drops, as I'm sure we will, the goal of treatment should not be to get a patient like mine who is on, whatever number, 9 installations or whatever she had per day, but as few bottles and installations as possible when using topical therapy. Questions and comments? I know time is getting short and I only have about 100 slides left.
I'm going to share the slide when you're done, Rich, but the answer to the MRI, I found it on the Glaukos website, is, and generally, yes, it says a patient with the iDose TR may be safely scanned under the following conditions. And that's what I remember the discussion being now, is that generally it's going to be the answer is yes, but there's these parameters that are listed here with regarding the watts and so on and so forth, watts per kilogram. But in general, a normal average MRI, yes, but if you start getting to maybe something specialty, injury could occur. So, and I'll share that at the end. So
yeah, so I'd certainly be careful making sure patients know that. So Greg, we have, I think, about 5 or 6 minutes. Yes.
Yeah. Go to 9:50 Eastern, so about 6 more minutes.
All right. So let's pick. I think we only have time for one topic, even though there's 3 or 4 more. So if you don't mind,
you pick. Dealer's choice.
Yeah. I'm a poker player. Okay. I got my topic.
Let me see if there's any questions rolling in while you're doing that. I think we're pretty well caught up. Skip any more polling questions. We've done well. We've got some good interaction. We've got
this has been great. I mean, okay. Neuroprotection. 20 plus years ago, we all thought we would have a neuroprotective agent, the holy grail. But we still don't. Some of you may remember the memantine study, which was done by Allergan back in the early 2000s, memantine being a drug that's used for other neurodegenerative diseases, but the memantine study failed. So we still have no glaucoma treatments that have been approved or have been shown to be effective other than IOP lowering therapies. So is there anything available? So just to review, neuroprotection refers to mechanisms and strategies employed to defend the CNS against both acute and chronic injury. And of course, the eye is part of the central nervous system. Excuse me. In glaucoma, it refers to non-IOP lowering treatments that protect neurons from apoptosis, or maybe even take axons that have been damaged but have not died and reverse the process. So I just want to talk about this interesting little study that actually came up at OGS. First author is Gus DeMarias. Gus is our surgeon at SUNY. He's a brilliant guy, brilliant researcher at Columbia, and he's at Columbia part-time. But a lot of it's work based on the basic science work of Simon John and Pete Williams. Actually, let me go ahead 2 slides here, and then we'll come back to this study. Essentially, some of the basic science work said that mitochondrial abnormalities may be an early driver of nutritional dysfunction in axons. And it kind of makes some sense, because if you think of a ganglion cell axon, that's a pretty active cell, or the ganglion cell is a pretty active cell. You know, it's transmitting information constantly along a very long axon into the LGN. So it makes sense that you need mitochondria that are highly functioning. So some of the basic science work has shown that a decrease with aging of NAD, nicotinamide, nicotinamide adenine dinucleotide, thank you, makes retinal neurons more vulnerable to disease. So in mouse models, mouse glaucoma models, we showed, or Simon John has showed, nutritional problems consistent with this. So oral administration of nicotinamide has really been shown to protect in the mouse model, and again, at the highest dosage tested, 83% of the mice in these studies did not develop glaucoma. So this may be a nice opportunity, and this is just a slide showing all of the insults that may lead to glaucoma damage that impact mitochondrial function and the mitochondria leading to cell death. So to back this up to the study that was done at Columbia, this was a phase 2 study of high-dose oral nicotinamide and pyruvate. And if you remember, pyruvate is part of the Krebs cycle and all of that. Not many patients, just 42 patients. But in the phase 2 trial, it was shown that these high dosages of nicotinamide and pyruvate were safe. And there was actually improvement of a number of the points in the visual field, although the median was only 2.2 months. So a very small study, but a proof of concept that some of these oral agents that affect mitochondrial function and cellular metabolism may improve visual function. And this, again, was in the short term. And that's really what this is saying. So right now, out of Columbia, there are 2 studies, the nicotinamide and pyruvate for open-angle glaucoma study, which is essentially the follow-up study to the one seen. And then another one is just with B3, which is a nicotinamide precursor, or nicotinamide is a precursor, both looking at the effects of these nutrition supplements. And the reason I thought it was important to mention this is I know many of the glaucoma talks that I've given, I always get questions about, what about nutrition? What can we do nutritionally to help our patients? And nothing's proven. Well, maybe this is something that will have some proof behind it that will actually be our first neuroprotective agents for glaucoma.
I think we might have, did we lose your sound, Rich?
Oh,
you're back. Okay.
Okay. Yeah, I
Perfect.
heard a click. Yeah, I heard a click too.
That was fantastic. We're right at 9:51. I'll end up with the kind of a comment on the nutrition is that, I really have taken a lot of functional courses over the last 6 or 7 years. And the reason being is that we as allopathic docs try to put a randomized clinical trial out there. And it's hard to do a randomized clinical trial on a chronic condition.
No question.
So what we need to do is there's what's called evidence-informed risk-adjusted medicine. So there's plenty of evidence-informed risk-adjusted medicine. It's just we as allopathic love that gold standard of randomized clinical trials. So, I'm a big proponent of nutrition. You have to fix the trabecular meshwork. It becomes oxidized. It becomes sticky. We can do some protection to that long axon that you just talked about and that ganglion cell. But that could be a whole other lecture that you and I can maybe do together at some point.
Sure, I'd
So,
love that. Yeah, just some of the things I didn't get to, but maybe another time in another place. There's always a lot of things to talk about. Um, Genetics is another that could be a round two.
yep, yeah.
Anyway, I just wanted to go there and thank you all for spending time tonight. There's my email if you have questions, and you can either send them to me or through Greg or any other way you'd like to get them, and be happy to chat with everyone.
So we're going to have about 2 minutes here, then I can do the housekeeping so we can be done by 10. But I'm going to remind everyone, if you look at your right side of your screen, fourth button down, survey, that little red dot's up. If you want to complete that while we're doing this wrap up, or you can wait for the post event. But here's a large one, Rich, and maybe you can just summarize it pretty quickly. Someone way back asked, what's your medication regimen for chronic open angle glaucoma?
So we're not including SLT in this
Yeah,
paradigm.
I
If
mean
it,
that could be a
uh,
whole new
yeah, well then
you know,
then it's a prostaglandin.
yeah.
I guess the question may be which prostaglandin, and you know, there's a lot to be said for branded prostaglandins. There's a lot to be said for branded prostaglandins that do not have preservatives. But at the end of the day, like everyone else, the um, generic latanoprost is probably going to lead the way because it's easier, it's cheaper, it's not going to get the callbacks from insurance. If that was not a problem and we had the best of all worlds, I would probably be looking to do a unpreserved latanoprost, or Zyoptan, which is unpreserved also.
Yeah, I'll probably just throw in there, you can go with the prostaglandin analog. Rich hit all the different highlights. Branded, non-preserved, probably non-preserved would be the best. But then adding your second medicine, I usually just go to a combination. We used to be taught single agent, single agent. Doing this long enough, I'm going to COSOPT or Comagan, adding that second medication and taking out that that SLT that we were talking about. So prostaglandin combination. And then maybe a Ropressa that's out there, Notarsadil, if we're trying to lower that low IOP.
Yeah,
Are
so
there
if
any MIGS procedures approved for standalone procedures?
yes, there are.
I know
Um,
hook blade is.
Hook is, Trebectome is, the iStent Infinite is now also, and that was a big thing for the iStent, the Glaukos folks, because that was one of the first of the kind of the stenting procedures, but it has now been approved as a standalone procedure, and that is a big deal.
Rich, go ahead and
Because
stop sharing your slides for a second.
sure.
And I think we're caught up on the questions. I want to share this super, super fast if I still have it up, which I think I do, so the audience can see. Let's see. I don't want to share that. Share that.
I gotta try.
Uh,
I gotta try my other camera now.
there you
It'll
go.
probably work perfectly. Yeah. Oh, nope, didn't. Okay, I feel better. Go back to the other one.
Screens, documents, advanced. Yeah. I was going to try and show the Oh, here it is right here. So this way with the MRI, this is going to the Glaukos website, and basically it says, yes, it can be done, but there's parameters out there. So for those that were looking for that.
Yeah, that's important.
Yeah, so it looks pretty normal. MRIs. I'm not certainly an MRI expert. I said look through a lot of Joe Salka's lectures, so hear a lot about MRI. But we're going to conclude this now by, let's see if I can find my slides to do the housekeeping. Where are they? Let's see. Do I have them up? Let's close this.
I really enjoyed the discussion. It was fun. I'm glad. Great questions.
I don't see them. Oh, here they are. I don't know why I'm acting up now. So everyone, there's that little red dot right here. If you go to the survey, you'll be able to start that. And we've done the questions. I want to thank everyone for listening to emerging questions in glaucoma management. Rich, always love listening to you. Easy
Thanks, Greg.
spoken, wealth of
Thank you for having me. It
knowledge.
was great fun. It was great
Yeah.
fun. This is beautiful the way this worked. Really nice. Really enjoyed it.